Well, hello and a warm welcome. Dr. Syl here, Junior Doctor from Australia. I'm on the psychiatry training program, and in today's video, we're going to do a little bit of a reflection. I'm going to talk a little bit about what it is like to be a psychiatry registrar, which in Australia is like a junior doctor on the training program to become a psychiatrist. In the States, it might be called a psychiatry resident. I think I'll split this video into 3 sections. The first will be to talk about my years so far, because I've been doing it for now about 9 months. And I'll talk about the different places I've worked as a junior doctor working in psychiatry. Then the second part of the video, I'll reflect on the day-to-day life, what it's actually like. What's the morning like? What's lunch like? What's the afternoon like? So let's get into it. So I started as a psychiatry registrar in February of this year, and different doctors will have different placements and terms in their training. But for me, I started in the kind of highest level of acuity in psychiatry, called like high security, high dependency. I guess we also call it high level of support, that kind of environment. And that really means that I saw a lot of people who had high risks because of mental illness. And that's really presentations that relate to mania. So people who are hyperactive, not sleeping, making terrible decisions, being promiscuous, risk-taking, hurting themselves, maybe hurting others, and also relates to psychosis. So I saw a lot of people with schizophrenia, drug-induced psychosis, and sometimes even psychosis because of a depression. So this term to start with was actually really good. You kind of see the very intense side of psychiatry and how bad things can get. You also see the patients in your area who have treatment resistance, and no matter what all the tools we have, we still don't get good outcomes. And that is a sad truth for some people who have severe schizophrenia or bipolar disorder. Working in that kind of high security unit also gives you a really good experience in 2 other areas. First, it teaches you about the law, because you have to understand the Mental Health Act. And every country, every state, has their own version of the mental health law that the doctors have to memorize, basically, or at least memorize the basics of. And so you have to actually often go to a tribunal or go to a courtroom to present your case why this person may need involuntary treatment, because this person doesn't want mental health treatment, but you're saying they need it. And so you really got to back that up. You got to justify that. And that's always a little bit of an interesting experience as a doctor, because you're kind of going to this mini courtroom. You feel like you're in an episode of Suits. You have a lawyer that's saying, well, prove that it's a mental illness. What symptoms did they show? How is that a mental illness and not just a normal a normal variant of normal behavior or atypical behavior, but not quite mental illness? And so you have to have your, pretty good, you need to be able to think quick on the spot, speak well, be polite, but also hold your ground. And the other thing that you get good at in high security or, high acuity unit is managing emergencies, psychiatric emergencies, so especially behavioral disturbances. So often there would be people who get very agitated, paranoid, violent, and the nursing staff, they need to have the tools ready to manage that if you're not there, especially out of hours. So, I got very comfortable with the right medicines to use to kind of sedate someone if they needed to, if they were in an emergency, but not so much that it would cause damage or respiratory compromise. So finding that right balance. And so that's how my first 6 months go. And now I'm in a different place, which is more of a voluntary unit. I mean, most people that are under our care in this unit want to be there. So instead of mania and psychosis, where people have lost touch with reality and don't have no insight, now it's much more depression and personality disorders, where they're very depressed and suicidal, or they're in a situational crisis and need a period of stability and support whilst they get their life back on track. And interestingly, this job it's probably less hours of work, but the emotional toll is far higher, because every patient is fully, a lot of them have very good insight and maybe compromised judgment because they're in crisis or because they're depressed, but they understand what's happening, and so you're much more involved in their care, and you connect much more to their families and get plans, and the planning is much more complex because if someone has psychosis, you do the review. I'm sorry, you have psychosis. You need medicine. And they say, I don't have psychosis. I don't need medicine. And you go, well, these are the reasons you do. I've tried for 5 minutes for everyone to try and convince them. It usually doesn't work. Then you just do the mental health act. You give them the medicine and they either get better. Some people have treatment resistance, but many of them get better. And I have plenty of patients who are like, whoa, I'm back. Like, that was psychosis. You were right. Thank you. And that's something I had to kind of remind myself of. And the doctor told me, it's like, you're doing them a favor by treating them involuntarily. Like, they have the right to not be psychotic and to receive world-class treatment. So I shouldn't feel bad for it. And that was something I needed to hear, because I was feeling bad about putting people on the act and giving them involuntary treatment. But that was a very important thing for me to hear, is that, no, I'm doing them a favor, because if they do get better, it changes their life completely. And that's super important. Changes their identity, like they've changed as a person back to a real person, and as opposed to this person who's psychotic and in this other world. But yeah, back to kind of what I was saying, it's much more simpler to manage people who are psychotic, because you can just make the plan and do the plan, and there's less negotiation because the people are psychotic. And then when they get better, it's more negotiation and working together. But when people are either in crisis or depressed but still have pretty good judgment, or good insight at least, it's much more involved. It's much longer reviews. And so although in this second term, I've got less hours of work per day. Like, I usually am able to get half an hour or an hour at the end of the day where I finished my jobs, but where I can study or do admin or something. But the emotional toll is way higher. I'm feeling way more exhausted. I'm feeling way more like, oh, I'm wrecked. But it's very important that I develop a ability to manage that, because that's life. I'm going to be dealing with patients like that the rest of my life. So I need to find my own strategies in managing the emotional toll that these reviews take, and keeping the healthy distance, but not so distant that I'm cold, and not so close that I'm enmeshed. And so that's kind of something I'm working on. So that's my year so far. As the next part of the video, I wanted to talk a bit about what does the day-to-day look like. So look, in both wards, in a classic normal day, you start the day with a morning meeting where the nursing staff, allied health, and doctors all go into a room and talk about the issues overnight and in the day before. So if anyone had a behavioural emergency, or if someone needs some kind of document, or if someone attempted suicide, or whatever it was overnight, that gets handed over in the mornings. And so that helps you prioritize your reviews for the day. And then you usually have a quick meeting with your team to plan who you're going to see that day, run through your patient list, run through the jobs that you know about, and then you get cracking with your day. And so usually you start off with reviews where you kind of go into the ward, you sit in a room, and patients come to you, and you see them with their nurse. You see, it's usually 30 minutes with a review. The first one's a bit longer, subsequent ones might be a bit shorter, but it averages around 30 minutes. So it's much longer than a ward round would be for medical teams or surgical teams. And you talk about the current issues. It's, I guess there's kind of three stages to people's admissions, if I think about it. So there's the crisis containment and diagnostic clarification stage, which is the first couple of reviews, where you're just making sure you understand the problem and stabilizing the crisis of whatever brought them into hospital, and you start treatment. And then the second phase is the kind of really treatment phase and monitoring treatment. And then the third phase is the discharge planning phase, making sure there's the supports and people at home and stuff. So different reviews will have different goals, but that's the kind of way I look at it. And then after the reviews in the morning, hopefully you don't have many more reviews in the afternoon, but the afternoon is usually for jobs. So that's where you'll call family members, get collateral history, have family meetings, write discharge summaries, a lot of file reviews to see what previous medications people have had and how they've worked and what didn't work. You'll do consults to other teams. A lot of people with mental illness who are in hospital will have medical problems that haven't been well managed because of their mental illness. And so we need to kind of opportunistically give them referrals to the cardiology team or the endocrinology team or whatever team it is, and get them, world's best care. That's what one of my consultants used to tell me. Syl, you got to give world's best care. So that's what that's what we try and do. And so now I want to talk a bit about the pros and cons of working in psychiatry. But before I do, I want to say two things. First of all, if you enjoy this kind of content, please check out my other videos, consider liking the video, and consider subscribing to the channel. That'd be really cool. But the second thing is I'm actually doing this on my new iPhone. I just bought an iPhone 15. So if you guys could leave a comment and tell me if you can tell that this was filmed on an iPhone, because I've also got a nice camera, but I want to see if I can actually just do it all on my iPhone and I can sell my nice camera. Because I've got two actually, so I probably don't need both if the iPhone works well. So tell me if you can tell that this is actually shot on an iPhone, not a real like professional grade camera. So yeah, for the last section, let's talk a bit about the pros and cons of working in psychiatry. So look, the pros, I really like a lot of things about my job, and I don't want to romanticize, no job's perfect, but the things I do like, first of all, it's very mindful. Okay, I'm sitting down, I'm connecting to people, I'm listening to their stories, and I'm trying to be present and connecting to their story and understanding their experience. So it's deeply empathetic, which is a good skill to have and throughout life. So I like that element. It's also mindful if someone is yelling at me and abusing me emotionally, or whatever it is. I try and always remain calm, even if someone's having an outburst, and that's good practice for me to manage my mindfulness and to manage myself. It's a lot of self-management in this job. The second thing is people who work in psychiatry are generally really nice. And mental health in general, people who go to mental health in careers are often super nice people. They're empathetic. They value your mental health because that's their job, and so there's a lot more balance in the life of a psychiatry doctor than other specialties, I would imagine. I guess there's a long list I could go through, but let's just go through three so this video isn't too long. But I guess finally, another nice pro is that the after hours roster is just simply not as brutal as other specialty training programs. So I do an after hours shift maybe maybe 3 times a month, 2 or 3 times a month, either on a weekday or on a weekend. And I do a set of nights 3 times a year, which is far less than a lot of other specialties. Now, in terms of the cons, I'll try and just pick three. I think the first is my frustration with psychiatry as a field in general, and that is that our diagnostics are really bad. So really the diagnosis of someone's mental illness is based on the judgment of a psychiatrist, on the objective and the objective observations and the subjective reports of a patient. So that it is influenced by their rapport with the patient, by what the patient says and doesn't say, and by a lot of things that are very difficult to control for, which makes it really not great quality diagnostics. It's not like hardcore science where you can get a blood test and say this person has schizophrenia because of this blood test. So that leaks into every area of psychiatry, and it causes issues in clarity of communication in people who get involved in studies. And then you say antidepressants don't work, but how many people in those studies that have depression didn't actually have a depression that responds to antidepressants? So there's going to be different types of depression in 10 years. There's going to be different types of psychosis in 10 years or 15 years as diagnostics get better. So I don't know, that's the fundamental, I guess, there's a fundamental problem in physics. That's the fundamental problem in psychiatry. I'm trying to think of other things I don't like, but I'm actually kind of struggling. I guess I don't mind this, but if people don't like, it can be quite exposing or performative. Like you've got to go in front, you got to go in front of a tribunal from time to time, and what I don't like, and I deal with it, but this is what a lot of people might not like. It is a confrontational specialty. Like this idea that you're going to be every patient's friend and make them feel better and save their life is pretty not based in reality. A lot of the time, actually, you've got to push people, and you got to tell people that things they don't want to hear because that's reality. So there's a lot of confrontation and difficult conversations. Every single day there's a difficult conversation, and so that probably leads to a third point, which is you get exposed to other people's either trauma or emotional abuse or seduction. That's common. So you got to be very aware that it can become quite you've got to learn to manage yourself and manage relationships with patients and staff and everyone really well. You need to be able to set boundaries, hold boundaries, and have difficult conversations. Some people who just want to stay in hospital forever, you got to go. You can't stay in hospital forever. It doesn't make people better in certain situations. In fact, staying in hospital, if people are regressing in their coping mechanisms because it's a safe space and they don't need to use their coping mechanisms because it's not the real world, can be really harmful, because then they lose their skills. And so you've got to sometimes discharge people who say, who say they're going to go do silly things or dangerous things on discharge, and that can be really difficult conversations to try and minimize risks as best as possible. So yeah, I think there's a lot of tricky chats, and that can be quite exhausting. And I think that's a good reflection. I think that covers a good range. So I'm going to leave it there. If you have any questions about it, leave a comment down below and I'll answer. And if you found that interesting, like the video, subscribe to the channel, and help support this little channel grow. That'd be awesome. And other than that, I just wish you all wonderful days full of love, and I'll see you all in the next video. All right. Bye for now.